All right.
It's cool that you guys let us do these demonstrations. Nobody else is really doing them.
Oh no, we love it. Well, and the thing about it is my point is that everybody thinks that it's pretty complicated.
Yeah.
And so that's why, that's why we love it when the students come because, we're blown away at how awesome like you guys are because it's
I don't feel like I did that.
So what year are you guys?
We're 30 years.
30 years, right? So at some point, there's a lot to know, right?
Yeah.
And at some point, as wonderful as the faculty members are, you're limited a bit by what they know, what their comfort level it is, and what they've done. You know what I mean? And there are some who don't know this, learned it the wrong way, and never done it, and they can't really teach it to you. They can give you some theory and disease state indications and things like that, but in terms of this part of it, they're not going to give it to you, And that's okay. It's not their job to give you everything. They'd have to give you enough that you can learn the rest. As long as they did that, they did their job.
I watched one of my professors do the amniotic membrane, and he put it like in the contact lens
Inside
first.
the lens.
And then
No, that's not the way to
wait
do
a
it.
minute. If you're gonna do this one, let's do
yeah.
That's cool. Although he's done it on me before without any numbing drops too. So it's cool. Thank you. All right. Yeah. It's
So you're going to hold her eye open, and once you have her eye open, you're not going to let it go until the bandage lens is on, okay?
Okay.
Okay.
your makeup is like doing great after having done all these demonstrations.
Should be in a commercial, right?
Yeah.
Never mind tear-proof.
Well, Helen's good.
perfect.
But remember, she's having an easier time because she saw you. So, good. Gently roll it on like a little rolling pin. Don't poke at it and tap at it. Gently roll it on.
Yep. Perfect.
Good. Thumb tends to be easiest when you're in front, but if your hand articulates a bit differently than mine,
She's so good.
good.
So are you.
Good job, Helen. That was like 30 seconds.
That was
Good
so
job.
easy.
Yeah.
Well, I watched
So
you.
now,
I
so
know-
let's-
you got me on it.
So
That is awesome.
So,
See? That's
so let's pretend
so easy.
she had some form of keratitis, whether it's, let's say, post-infectious herpetic keratitis. You want to offset the risk of visually significant scarring. She's had some prior ulceration, maybe herpetic ulceration. You want to offset the presence of neovascularization of the cornea, so she's not primed for a more robust response next time around. Let's say she's had chronic dry eye, not getting better with appropriate dry eye treatment. She has reduced corneal sensitivity. There's a neurotrophic component that's there, suggesting the feedback loops on the front of the eye are not allowing her to have optimal ocular surface self-maintenance. You just knocked out a lot of stuff by introducing the membrane. You introduced key growth factors for healing. You introduced nerve growth factor to get those feedback loops functioning normally again. You introduced anti-fibrotic factors, anti-VEGF factors to reduce scarring and neovascularization. You did a lot of good stuff all at once. You're going to bring her back between 2 and 7 days from now, depending on what her case really is. And you're going to take the lens off. She's going to look and feel great. For the duration of treatment, you would give her probably something like Maxitrol or Tobradex, combination antibiotic steroids, so that the risk, because when you sleep with a contact lens, the two risks are infection and oxygen. They're both at bay now. Yeah.
Very cool.
Yeah.
Thank you, guys.
Yeah. No,
Good, guys, no
absolutely.
problem.
Yeah, and yeah. If what was her name? The contact lens.
Jillian.
Jillian.
Yeah.
She's
I'll
around.
bring
bring
her
her
We'll
back.
come back later.
Sure.